Medicos. As promised, AIM4PG will give lectures every week. So today's topic is diabetic ketoacidosis management. Strict will discuss the diabetic ketoacidosis management in hospital setting. It's a common that diabetic ketoacidosis present in the patient and they present in the hospital. So let's start. Now, before telling about diabetic ketoacidosis, let's discuss what is the factors that precipitate it. Like it can be failure to take insulin, failure to increase insulin, like in illness, pneumonia, myocardial infarction, stroke, acute stress, like trauma is more emotional, and medical stress, which counter-regulate the hormones, oppose insulin, and stimulate glucagon release. Hypovolemia also sometimes leads to diabetic ketoacidosis, like increases glucagon and catecholamines, decreased renal blood flow, and decreased glucagon degraded by the kidney. We can say the DKA, diabetic ketoacidosis, will be defined when the three presentations will be there, and we can also add hyperosmolarity. The main three components that leads to DKA are hyperglycemic, which will be blood glucose level will be more than 250 mg per dl, and ketosis that will be present in your urine and blood. Ketones will be present, and acidemia, that is pH, will be less than 7.3. Bicarbonate would be less than 15 MEQ per L, and hyperosmolarity, which I am keeping it at fourth point because the three above points are more important. Now the patient will come with signs and symptoms when he will be presented with DKR like polyuria, polydipsia, dehydration, uh, trachycardia or orthostasis you can say, and orthostasis and trachycardia can be seen by the dehydration presentation, and abdominal pain which will be leading to nausea, vomiting, fruity breath in their when the patient will come you can smell the fruity breath in them, which is due to the acetone, cosmal breathing, and mental status changes like the patient will be like drunk or coma or competitive. The above we discussed the signs and symptoms. Now, what is the physical finding in the patient? There will be tachycardia, dehydration as we can see, hypotension also, and tachypnea, cosmal breathing, respiratory distress, and fruity odor due to the acetone. Abdominal tenderness will be there, which may resemble like acute pancreatitis or surgical abdomen. And lethargy, the patient will be presenting lethargy, very fatigue, like a coma and cerebral edema. Now we can say why the role of insulin is there in decay, because insulin only transport of glucose into a muscle and adipose, and it can also inhibit lipolysis. And absence of insulin can lead to glucose accumulate in the blood and use amino acid for glucogenesis, convert fatty acid into ketone bodies, acetone and ac- acetoacid. So you can see the ketone bodies in the blood and urine in decay patient. Now we need to differentiate and HHS. Now you will say DK is diabetic ketoacidosis, but it's HHS. HHS will discuss later. That is hyperosmolar, hyperglycemic, non-ketotic state or syndrome. Now the both will be present similarly, but the main difference will be glucose in DK patient will be 250 to 600, but in HHS, that is hyperosmolar hyperglycemic state, will be more than 600 to or 1200 mg per dl, and the sodium will be in DK 125 to 135, but in HHS it will be more. Potassium will be normal to increased, but in HSS it will be normal. Osmolarity will be 300 to 320, but in HSS it is more. And the main difference is here, plasma ketone. In decay, it will be more, but in HSS, it will be slightly less or more, and sometimes maybe absent. Bicarbonate will be in decay, it will be less than 15 MEQ per L, and in HSS, it will be slightly in lower side. But here is the main difference again. Decay arterial pH will be 6.8 to 7.3, but in HHS, it will be more than 7.3. You can see the two three differences, and arterial PCO2 also 20 to 30, here it will be no, in HS it will be normal, and angle will be increased, and in HS it will be normal or slight increase, but the main difference will be ketones and the pH level and the glucose, the main three components. Now, if as I have told about the HHS, let me describe some of the HHS points so that it will be helpful for you for differentiating. In HHS, there will be severely dehydration, and the patient position will be supine or the orthostatic hypotension like presentation, and the patient will be confusion, and the neurological finding you can see seizures, hemiparesis, hyperreflexia, or generalized areflexia. As I have told, the main three difference will be uh, glucose will be more than 600 mg per dl, sodium will be slightly normal elevated, potassium will be normal elevated, bicarbonate will be more, and the osmolality will be more than 320 uh, MOSM per L. And the main difference, ketones will be not present here, but in decay ketones will be the main component. And we can cure the diseases in the same way like decay, but here NS need to give rapidly because we need to fulfill the dehydration rapidly. But it will be not good if I don't tell you decay treatment, but saying you directly about HHS. So let's go into decay treatment. And but just for your information, I told the HHS treatment. Now, how to treat decay? The main topic starts now. The management of decay in your hospital settings. Previously, I gave some short history how what is decay and everything. Now, coming to the management of decay, how can we manage? Initially, we'll replace the fluid electrolytes, give IV insulin therapy, watch the complication, treat the cause, and once resolved, we give home insulin regimen. Now, let's start. Now, for diagnosing and confirming, we'll send the blood reports of patient and find out what is the CBC, serum ketone or urine ketone and sugar, blood sugar, calculate serum osmolality and anion gap, and urine assistant urine culture. Consider the blood culture and consider chest radiography. It is also important, and acid base management. Now, what is the guideline? When we take the admission, as you know, we did CBC, blood glucose, electrolyte, creatinine level, urine ketone, plasma ketone, and ABG, arterial blood gas. Now, secure two IV lines. Line 1, give 10 units of human regular insulin, IV bolus, 50 ml of NS normal saline plus 50 units of HAI, infuse as per our ICU setting and the insulin protocol. Line 2 will be IV fluid replacement, usually normal saline plus potassium replacement. At the rate we can give 200 ml per hour. Rate of infusion to be less and EF is low. And for 4 hours monitor ABG and potassium 2 hourly. Line 1 continues insulin injection as we have secured the two IV lines. And line 2 continue IV fluid. Can shift to half NS in case of hypernatremia. And same way we have to do the potassium replacement. Change to 5% dextrose when the blood glucose drops to 200 mg per dl. As it is more than 250, we give the insert treatment. Now when the blood glucose level decreased to 200 mg per dl, we started giving 5% dextrose. Start KCL with 40 MEQ per L of IV fluid if serum potassium is less than 3.5 MEQ per L, or if urine output is good and blood glucose is dropping. Now, for 4 hours we did. After 4 to 24 hours, what we have to do? Monitor ABG and potassium 4 hourly. And the two IV line we have opened. Line was we have to continue with adjust insulin infusion rate as per our ICU protocol. Here ICU2 is written as per our hospital setting. So as our protocol we have to do and maintain the blood sugar between 140 to 180 mg per dl. And in line 2, we have to give NS or 5% dextrose IV to correct half of calculated fluid requirement or KCl 40 mg EQ per L of IV fluids. Now, as 24-hour, 1 day has gone. After 1 day, what we have to do? Repeat CBC, electrolyte creatinine once per day. And in line 1, we have to continue giving IV infusion as per our ICU protocol of hospital. And line 2, we have to reduce IV fluid when able to retain fluid orally. As the patient will start oral diet, we have to reduce the IV fluid. And after 48 hours, shift to the oral feeds, start multi-dose insulin regimen, subcut as per split dose given by the our diabetologist and our endocrinologist. Potassium therapy in DK, what you have to do? Do serum potassium initially every 2 hours for 4 hours, every 4 hours and next 12 hours or 12 hours thereafter. Initial serum potassium is low, high or normal. If initially potassium is low, give 40 MEq per kcal per S. Output is adequate, more than 50 ml per hour. When the potassium will drop precipitously after 2 to 4 hours of treatment and successful lowering of blood glucose, continue 40 MEq of LKCl of IV fluid administered. Bicarbonate therapy in DKA is important. Give bicarbonate only if pH is less than 7.2. Give half of the calculated dose and give sodium bicarbonate diluted in NS or 5% dextrose in ratio of 1:4, like bicarbonate 1 part and saline 4 part. Over 1 year, for 1 hour, we have to give. And we have to monitor the ketone, keep monitoring the ketone. Urine ketone to be measured 4 hours initially for 12 hours, followed by 6 hourly for 12 hours, followed by 8 hourly till disappearance of the ketone from the urine. Other important point we have to remember, like treat the underlying cause of decay, which can be acute myocardial infection, sepsis, stroke, etc. That we have told the precipitating factor which can lead to the decay. We have to check and treat these causes also. Urine ketone will decrease initially but reappear thereafter before the final reduction because of conversion of acetoacetate to beta hydroxybutyrate. Avoid NaHCO3 therapy until pH is less than 7.2 to avoid cerebral edema, as it can cause the cerebral edema, so better to avoid. Now, what can be the complication of DKA? Which it can lead to infection, which can precipitate to decay, fever, leukocytosis in secondary to acidosis, shock. If not improving of fluid, rule out the MI. Shock can be there. Vascular thrombosis, severe dehydration, cerebral vessel occur hour to hour after decay. Pulmonary edema can be there. Result of aggressive fluid resuscitation. Cerebral edema, first 24 hours, the complication can be mental status change. And if there is cerebral edema, give mannitol. As you know, it is a standard treatment. If cerebral edema is there, give mannitol. May recur in intubation with hyperventilation also if there is cerebral edema. So, how do we prevent decay in early setting? We have to guide the patient when they visit for consultation. We have to uh, make aware about the decay and everything. Never omit insulin. We have to ask them never omit insulin. Cut long acting in half. Prevent dehydration and hypoglycemia. Be dehydrated. Ask patient to be always dehydrated, and uh, never ask them to take low sugar because it can lead to hyperglycemia. So it would be maintained to a normal level. Monitor blood sugar frequently. Monitor for ketosis. Provide supplementary fast-acting insulin. Treat underlying triggers. Maintain contact with medical team. Like they have to do checkup and everything in regular basis. So this is all. Thank you. Hope you are understood with DKA. If any issues, you can post in our M4PG group, and visit regularly m4pg.com for quiz and more lectures, and our YouTube channel for more lectures. Also, we'll be posting all these notes and PDF in our M4PG notes group. And never forget to join the M4PG Telegram group. And thank you from www.m4pg.com. Thank you. Hope you understood that diabetic ketoacidosis management in Honda hospital setting.